Welcome, everybody. My name is Joe Feldsien. We're here today to talk about the mouth-body connection and the link between oral health and heart health. I'm the Senior Vice President of Clinician Technology Enablement at Pacific Dental Services. Today's conversation will focus on the oral systemic link as it relates to heart health. Steve Thorne, founder and CEO of Pacific Dental Services, will host Dr. Bradley Bale and Dr. Amy Doneen, co-authors of the book Beat the Heart Attack Gene and co-founders of the Bale-Doneen method. Conversation today will be about 45 minutes long, give or take, and we'll have about 15 minutes at the end for Q&A. Please feel free to submit your questions at any time using the chat function. And with that, I'm going to turn it over to Steve. Take it away, Steve, and tell us a little bit about about your relationship with Dr. Bale and Dr. Doneen.
Yeah, thanks, Joe. This is a pleasure to be with you two today. It's an exciting time in dentistry. The journey for me started about 5 years ago. We put together a team at Pacific Dental to start studying hard and collecting the data, actually, more than studying, but collecting all the data, all the science from around the world around the mouth-body connection and the link between what's going on in our mouth and you guys all know I'm not a dentist, so the bugs in our mouth and how it is affecting our body. And it didn't take us too long to go to, as this group worked through the science, said, hey, look, we gotta jump on this in a big way. And so I asked the leader of the group, hey, who's one of the best in the world that you can hook me up with that's passionate about this on the medical side? And he introduced me to Dr. Bale. And that's when we met a couple years after that, I think. And I said to myself, hey, if I really believe this and if this is real, I'm going to sign up and be his patient. So I am, in full disclosure, I'm Dr. Bale's patient. I have been for 3-4 years now. I've learned so much. It's been great. So that's the connection, and most of you in the industry know that PDS is going full force around the mouth-body connection, and we are trying to lead that effort in dentistry as dental and medical become more integrated. So that's the story, Joe, but let's just get into questions if that's okay. Right? Or I guess we should do a quick intro real fast, huh?
Yeah, do a quick intro.
Yeah, Dr. Bale, why don't you go first and just a quick intro.
Yeah, I'm Dr. Bradley Bale, and along with Dr. Amy Doneen, we developed a method that halts arterial disease. And a critical element in getting that accomplished is making sure the patient has a healthy mouth. We realized some time ago that the science supported the fact that the pathogens, the bacteria in the mouth can drive inflammation to the point that it can cause arterial disease and trigger heart attacks and strokes. So we were very happy when Steve Thorne came to one of our courses several years ago and showed his excitement about the oral systemic connection. Because for Dr. Doneen and I to accomplish our goal of preventing heart attacks and strokes, we have to have educated oral health care specialists right by our side, or it's not going to happen. I'll let Amy introduce herself.
Great, Dr. Doneen.
Yeah, hi, thanks for that. I'm Dr. Amy Doneen, and I'm coming to you from Spokane, Washington. So hello, everyone. And yeah, Brad and I have worked together for over 20 years now, and we have worked diligently to focus on arterial disease through the lens of inflammation and basically a very specific program that's individualized for each patient. So we use genetics and we use inflammation as our backdrop, and probably about 10, 15 years ago, we realized that the things that we are treating clinically, which include common things you would think for arterial disease, like lipids and blood pressure and prediabetes and genetics and all of that, that if we didn't pay attention to the oral health, both the periodontal health and the endodontic health, that inflammation can spark. And it's in a wheelhouse that's totally outside the medical arena. So we started to really learn and focus. And we met Dr. Tom Neighbors several years ago, who told us about, you know, you can actually test for these high-risk periodontal pathogens. And so we've kind of worked into this and have had the honor to work with the dental community to really bring dentistry and oral health care into our method of heart attack and stroke and microvessel disease prevention, keeping the brain healthy, the eyes healthy, kidneys all the way down to the toes. So we feel very strongly that in the world of cardiovascular prevention, we could not get our patients healthy without partnerships with each patient with their oral health expert. It's just that important.
That's a great segue into my first question, which is, I've been in dentistry 32 years, and most dentists understand there's some sort of relationship between periodontal disease and other inflammatory diseases, cardiovascular disease, Alzheimer's, diabetes, and things like that. But tell the audience about some of the specific studies that that caused you or convinced you that it's much more than just a relationship. It's actually, I think, in some of the studies, causal. So, Dr. Bale?
Yes. Yeah. Well, again, Dr. Doneen mentioned it was 10 years ago that we met Dr. Tom Neighbors, and that was instrumental and a landmark meeting for our Bale-Doneen method, because he brought testing for the actual pathogens that drive the risk to the United States through DNA testing, salivary testing, because we did realize that it's the systemic issue from periodontal disease and endodontic disease that drives the risk. So in other words, the definition, like a periodontal disease, which has been simply how deep is the pocket, how much bleeding do you have, and how loose the tooth is, that's not going to drive a systemic problem. What drives the problem is the bacteremia that goes on in all of us every day from the pathogens that are in the gum tissue. And if you have an endodontic disease, those pathogens are going to get throughout the whole body through the circulatory system. So it was instrumental to know that that could be tested, because there are certain high-risk periodontal pathogens that have been shown to be actually causal of arterial disease. And that study was published several years ago in Postgraduate Medicine, which is through the British Medical Journal group. There are 3 things that are necessary to cause arterial disease. One's a concentration of the bad cholesterol. Another is inflammation of the endothelium. And another is the trapping of the cholesterol particles in the wall of the artery. And in that paper, it was shown how the high-risk periodontal pathogens actually are causal of all 3 of those steps that are necessary to form disease in the artery. It's called the atherogenic triad, and the high-risk periodontal pathogens actually enhance all 3 steps. So it was accepted that those pathogens are causal. What's missing still in most studies, unfortunately, is when they study periodontal disease, they define it still, for the most part, as how deep is the pocket, how loose the tooth, and how much bleeding there is. Right. That's unfortunate, because you're not going to see any studies that are conclusive showing that treating high-risk periodontal pathogens lowers cardiovascular risk until it's defined by those high-risk pathogens. Because again, it's not how deep a pocket is that drives the arterial risk. But there's no question the science is solid, and the INVEST trials were the first trials that started specifically looking at those pathogens and showing how they drive the arterial risk. And then in terms of triggering heart attacks and strokes, Dr. Pesce published several years ago in American Heart Association journal a study that implies potentially up to half of all acute heart attacks are being triggered by the pathogens from endodontic disease. So the science—
I remember you telling me a story or a statement that one of your, and tell me if this is true or not, if I remember right, that one of your concerns for your elderly patients, one of your major concerns is endodontic abscesses.
Absolutely. Yeah, his study was very strong, implying that, again, a huge percentage of acute heart attacks are literally being triggered by that type of endodontic infection. So one of the first places a patient should go after they've had a heart attack is to an oral healthcare specialist to be thoroughly evaluated, not only for periodontal disease, but occult endodontic disease.
Yeah, yeah. You mentioned inflammation, so I'm going to switch over to Dr. Doneen. What's the role inflammation plays, and how does that all work out in our mouth? We as typical patient, and we're not a clinician, we have a little bit of inflamed gums. We all think that's normal.
Mm-hmm.
What role does that inflammation play?
Yeah, good question. Well, first thing I think to set the stage, that arterial disease is an inflammatory process. Both the development of arterial disease, which grows in the wall of the artery, and also plaque rupture, thrombus, which is driven by some sort of inflammatory trigger. And as Brad mentioned, with Pesce's data, it could be an endodontic lesion where the bacteria can cause that trigger, and also the causal data with bacteria in the gum line, A.A.P, TFTD, and FN, which can cause inflammation through the atherogenic triad. So with that understanding, it was really validated with the CANTOS trial several years ago, where basically using genetics and using sort of monoclonal antibody therapy where you can attack a pathway that drives inflammation, it was proven beyond a shadow of a doubt that inflammation is the driver of vascular disease and you know, event production, basically. And so when we look at all the root causes of vascular inflammation, they're immense. And periodontal disease, through, as Brad articulated, the atherogenic triad, we were able to demonstrate how these pathogens can actually drive the development of atherosclerosis. And with understanding that, clinically, we can, Steve, make everything look pretty. We can treat the cholesterol, we can treat the blood pressure, we can get even psychosocial support, we can get the diet fine-tuned with genetics, we can do all of these. And if we don't appreciate the fact that periodontal disease drives inflammation through all of these pathways of innate immunity, adaptive immunity, direct damage to the artery wall, and also direct pathogen invasion, we're going to be on a very volatile platform of trying to stabilize this atherogenic disease process in each individual patient. And that's why it's so critical and such an honor, really, to work with the dental community to make sure we are in partnership to affect all root causes of vascular inflammation.
Yeah, we can talk about my specific example in a minute, but I want to continue with this on a more granular level. Most of the audience are in the dental field. So when you talk about the genetic test, what specifically are you looking for? And then go through some of those, the other bacteria. You rattle them off like that. You rattle them off faster than a dentist does. And go through a couple of those just for the audience to really understand the granular level of what we're looking at. So let's start with the genetics. I don't know, Dr. Bale?
Okay, well, some of the genetic testing that we like through the oral health care provider is a panel of tests that'll tell us how much inflammation the patient is likely to generate from some of the cytokines that'll be produced when you have these periodontal pathogens like tumor necrosis factor alpha, interleukin 1 beta. And genetically, some people are programmed to have severe inflammation when those are released. Other people, it's not as severe. And then that oral healthcare provider can utilize that information to get a better handle on how close an eye they need to keep on that patient who has some of these pathogens. And some people may need to be recalled every month or two for a while.
Right.
To make sure that
I want to interrupt you a second. I'm going to lay out, be fully transparent. So who's your patient that has that and has had to change their behavior because of what you've taught me?
Yeah, you're looking at him, Steve Thorne. Yeah, for sure.
I got a bunch of those bad genes.
Yeah, yeah, and you got a high-risk periodontal pathogen. At the time we checked you, it was Treponema denticola, which is a bad bug, and actually that one, along with PG, Porphyromonas gingivalis, are associated actually with increased risk for Alzheimer's disease as well. So our method does reach way beyond just preventing the heart attacks and strokes.
Right.
And the oral care that a dentist and hygienist provides is not only reducing the risk of heart attack and stroke, but they're reducing the risk of Alzheimer's, dementia, heart failure, kidney failure, even erectile dysfunction, because we now know that most events, so to speak, when somebody has the quote heart attack or stroke, they get the blood clot from the artery. Most of those are silent, and the clot's really small, and it'll break loose and travel downstream till it plugs up the smallest of arteries, the arterioles and the capillaries. And that leads to microvascular disease, which the patient's unaware of. And if that continues to go on after 10 or 20 years, they do become aware of it. It's like, well, I can't remember where I live, or my heart's failing, or I can't get erections anymore, or my kidneys are failing. So the dental providers and hygienists need to know they're doing much more than making pretty smiles. They're not only saving lives acutely from those bad, horrible, symptomatic heart attacks and strokes, but they're helping to prevent the diseases of aging, which rob all of us of our quality of life as we continue to live. Most people outlive their health. And one reason they outlive their health is because they got a bad mouth. And they develop microvascular disease.
And you know my history. I come from a family of dentists. My father is a dentist, still practices. My grandfather is a dentist. Two of my brothers are dentists. One happens to be a periodontist. And they don't even get into this level of granular detail, because in my mind, and help me understand this as a non-clinician, you've got to start with those genetics to understand, am I more susceptible or not? What's going on in my mouth? Why is my mouth always having problems? Because once you understand that, right, then the dentist, the oral healthcare provider, can get the patient, me, in the right cadence of care. And then we can monitor the bacteria. Did I say that right, Dr. Doneen?
Yeah, oh, that's great. Yeah, and Dr. Doneen probably has some comments to make in this arena too, I would think.
Yeah, I heard you recently speak on, I'm going to switch it just a little bit to go a little deeper here too, on oral cancer, sleep apnea and oral cancer. But touch on sleep apnea for a minute, because what I heard you say, I mean, you know this stuff cold.
Sure. Yeah. Well, Steve, you did get it right when you said, to establish an independent cadence of how often you should get into your hygienist, how often should you have your cleaning. We base every treatment to the N of 1 in our clinical practices, and that means what's best for you may or may not be best for the next person. And not to get into it too deep, but it's a relative conversation. Historically, my patients would go to their dentist twice a year because that's what their insurance paid for. And that was it. And when we, in partnership with the dental community, are measuring their inflammation panel or burden of inflammation, if we're not seeing those levels maintained at optimal levels, and we will pick up the phone and call the dentist and say, we need your help. There's inflammation going on with this patient that is outside of our normal cardiovascular risk profile. Everything else looks good. And so to work in partnership with the dental community to find out what is driving, or if they've got a silent endodontic lesion, or if those periodontal pathogens are continuing to drive the inflammation. That's how the connection really works. And one of the root causes outside of periodontal pathogens, endodontic pathogens and lesions is airway. I mean, there's no question that airway is such a huge component, both from the hypoxic standpoint, both from a sleep disruption standpoint, apnea for sure. And we work very closely and really believe strongly that the dentists who focus on airway are tremendously helpful in the medical arena. So we really appreciate the fact that dentistry is grabbing hold on airway and really becoming key partners in ensuring proper sleep and airway health.
A question for you. I know with your patient pool, you probably know this for a fact, but outside of that, do you know of studies that show the overall either reduction in healthcare costs, patient healthier, anything around those, around that idea that can help bridge this big gap? There's still this big gap between the medical field and dentists.
Yeah.
And how we bring that together, because I mean, I'm one, I'll probably live a few years longer because of Dr. Bale, I hope. What studies are out there?
Yeah, sure. Joe, if you can put up Jeff Coates' study, that would be helpful, and then I can kind of talk through it a little bit.
And one other question came across. What about, we're talking about periodontal disease, but another question came across about edentulous patients.
Yeah. So edentulous patients can still have oral inflammation as we're understanding it. And all patients basically need to have optimal oral health, whether it be edentulous or patients that have old root canals that could be inflamed and just don't feel it. I want to make a mention of this because, Steve, you brought it up. Are there any studies that show the benefit of dentistry from a financial endpoint to diseases that we're dealing with on the medical side? So one thing I will say, and we welcome, and Pacific Dental Services is going to be key for this, because as dentistry changes their diagnosis of periodontal disease to one that we're asking for, which is not just the physical exam of pocket depths, presence of bleeding, etc., but rather what is the burden of pathogens and what is the understanding of that patient's innate and acquired immunity response to those pathogens. So a lot of the data we have, historically financial data, is based on an old definition of periodontal disease, and I think that's important to point out. But there's really one. Yeah, there's really one that is available and at our fingertips, and it's Jeff Coates' study, because what they did is they looked at an insurance model that they shared dental and medical insurance profiles, and they looked at individuals who had been diagnosed with periodontal disease by a traditional model, and they looked at outcomes as far as hospitalizations, medical visits, prescriptions, etc. And they show that those people with documented periodontal disease the old way, when they were treated 4 times a year versus the historical more come in when you need to type of approach, you can see how treating gum disease lowered medical costs annually in a tremendous fashion, lowered stroke risk, saving $5,681 per year on average per patient. Diabetes costs were down, reducing hospitalization.
Per year? Those are per year? Wow.
Yes. Yes,
Unreal.
for patients. And then when you look at the treating gum disease, reducing hospital admissions for people with diabetes, treating gum disease, take away everything else, take away their sugar treatment, take away all of that. Hospitalizations were down in diabetics by 39.4%. Now take that grandness, and if you look at, if you can go to the next slide, Joe, I want to put something in perspective because it's really interesting. And it shows the apathy that we're dealing with right now. When you look at just backwards at 2012, and sadly things haven't changed a lot, but you look at the distribution of national healthcare dollars, and in 2012, healthcare dollar was only given to about 5% of the energy given to the importance of oral health. The majority of healthcare dollars are spent on end stage disease. Things like, as you can look in the bottom right-hand corner, that's home health care. When you look at sort of the light purple division, that's going to the doctor and nursing homes, et cetera. So we're spending our money trying to pick people up after they're extremely ill. And as Brad mentioned so beautifully, what we're dealing with in medicine is that our health plan is not matching our lifespan. So people are spending on average about 12 years of poor health while they continue to live their lives. And that's partly what's driving this horrible sort of statistic of everything we don't want. But we believe very strongly that based on Jeff Coates' data, and if you can go to slide 8, Joe, if you don't mind really quick, if we use this opportunity and say, you know what, oral health is an essential element to an individual's general health and quality of life. We believe that oral health professionals need, not should, need to be viewed as indispensable partners with primary health care, with everyone. The team needs to include the oral cavity. There's just no question about it because of the inflammatory burden. Whether you call that periodontal disease, endodontic disease, or airway, the oral healthcare specialists are key members of the team. And I'll just say one more thing and then I'll hush up a little bit here. But, you know, Brad and I have 3 academic appointments. We teach at the medical school here at Washington State University. We teach and work with the University of Kentucky College of Dentistry, and we also work with Texas Tech University Health Sciences with one goal in mind, and that is to get people to talk to one another. So when we are working with the residents in the family practice medical school, we're teaching them of the importance of talking to children and families about oral health, and here's why, and bringing in the idea of inflammation. And it's just such a key resource. And, you know, if you've got a child who's dealing with PG and they have, you know, gum lines that seem to be hard to keep in control, if they've got PG, they've already got the opportunity to trap those lipoproteins in the artery wall and get fatty streaks development before they're 20. Even in children, and it's an oral health issue. And unfortunately, we, Brad and I, see these patients when they're 50 and 60 and already have developed atherosclerosis. When really, if we appreciate the lifespan, and then dentistry sees the patients more often, Steve. Dentistry sees patients way more often than in medicine.
So I'm going to give you a quick update what PDS has been doing, and then ask you some questions about what we can do as an industry, and most industry in the United States, and then, you know, in the world too. So we are so committed to, I think, you know, we have 3 integrated practices where dental and medical are in the same building working together. The issue that we faced was they don't work in the same EHR. They don't work in the same healthcare record. So looking at the data, looking at the science, looking at the lipid profiles and all those things has been hard, actually, because they don't work in the same EHR. We're moving the entire organization over to the Epic platform so we can have integrated practices. The physicians and the nurse practitioners and the dentist will work in the same record, same EHR. And with Epic, it obviously integrates with the majority of the system, health system out there. So we are super excited about that. Now, because a lot of these people that have periodontal disease are elderly, and most of them don't have dental benefits. Back to your slide, once you hit Medicare, you don't get dental. I mean, what can we do?
Yeah, well, first of all, congratulations to PDS for going to that Epic program where it is integrated for dental and medical. So PDS, I think, is leading the way for the whole world, because this is a global issue.
Right.
Just in the United States. I mean, cardiovascular disease in any developing country is still the #1 cause of death and disability. Even with COVID-19, it's still leading the way. Almost 3,000 people a day die in the United States of cardiovascular disease. And until we have solid integration between medicine and dentistry, that's going to continue, because a huge number of these events are being triggered by poor oral health. So this has to happen, and that's why that Jeffcoat data is so impressive. You saw the huge decrease in monies needed for people who have diabetes, people who've known to have strokes in the past or have known heart disease. Making sure that oral health is in place has huge financial benefits, and that's going to be the case all over the world. So I think you're going to lead the way, and PDS better get ready to become a global industry. Seriously, why not? I mean, we're all human. We all deserve this type of
care. I don't have any more hair to lose.
Away, and you've shown people how to do it. You should go global.
Well, let's bring it. I'm with you. I love the passion. How about just medical carriers? I know the Jeffcoat study, and there are other studies. I saw a great study by Blue Cross Blue Shield of Hawaii recently, and it was done by the physicians. Incredible study around diabetes. How do we get dental oral health care covered by these medical plans so patients can get the care they need? Is that where we should go?
I'll start with that one and offer some caution to the world of dentistry, even wanting to jump into the arena of medical insurance. Okay. It's not my field of expertise, because I decided long ago to drop out of the medical insurance world for my clinical practice. And it's been a successful idea because patients want good care. So medical insurance is a catastrophic healthcare plan at best. Medical insurance covers us when disasters happen. And that's part of the challenge it's almost like a sick care model rather than a wellness model. So I don't know, and I don't want to be perceived as any expert on this, but I'd be cautionary for dentistry to want to jump into that model, because what dentistry has done better than medicine is focus on the value of prevention, getting reimbursed by carriers for dental hygiene care, getting reimbursed for things that in medicine, it doesn't happen. And so I would just offer that cautionary thing. With Epic, though, I think that is such a brilliant step that you've done, Steve, because getting the charting and the electronic medical record dialogue going and be able to access records at a fingertip is going to really elevate the continuity of care. And I think that's incredibly impressive, number one, and extremely important. But having dentistry jump into the medical arena, while it sounds nice, I'd be cautionary.
Yeah, I hear you. And on the other side, it is a debate for sure. And I think the Jeffcoat study was Aetna, if I remember right, right? And and yet most dental plans haven't changed in our lifetime. So that's what we struggle with on the dental side, right? So prices have gone up, costs have gone up, and all that, but you know, most aren't going to reimburse you for for 4 visits in the year, during the year, if you have periodontal disease. So
Yeah.
I'm looking for angles how to get that. And I think with the carriers, my take is, with the big carriers getting the savings, the medical side, they get the savings. So my angle is that they should pay dentists for helping out in that savings. So that's where I know that's a big lift, but
I don't disagree with you. I just think it's kind of a, I totally agree. I wish there was an ICD-10 code that we could use in medicine to say this arterial inflammation is absolutely being driven by periodontal disease. This patient absolutely has to be supported to get into their oral health care specialist more often.
I'm going to get you and
Yeah, I agree with.
Oh, go ahead, Dr. Bell.
Yeah, I agree with both of you, but I think we can't forget anything great in life begins with education.
Yeah.
So we all need to spend more time educating our patients, educating the consumer on the science, which is solid behind all this, and the value of making sure you have a healthy mouth. And when the people get educated, they very well may be willing to pay whatever they need to pay to make sure their mouth is healthy, realizing it's going to save them lots in terms not only financially, but with the quality of life that they maintain for however long they live. So I think more needs to be done with educating the consumer, and consumers are looking for education. And I know in medicine, consumers have figured it out that a lot of medical providers, it is just wait till you get really sick. You have some end-stage disease, and then we'll try and take care of you. There's more and more direct-to-consumer education going on, and I think that's extremely important. And I think it'll help tremendously with what you're talking about.
Stay tuned. We've got big plans for our Smile generation, and I'm just waiting for Epic to get implemented. So stay tuned on that, Dr. Bale. We're going to do some public education around.
We'd love to help you with that.
Yeah. 2 last questions. The one, what do you say to the skeptics? I've spoken on this publicly so many times. I'm actually viewed in the industry, even though I'm not a clinician, as kind of an expert on this, and I am not an expert on this. You guys are the experts. But what do you say to the naysayers out there that still don't get it? It's still not taught in all the dental schools. Some are getting there, couple. I know which ones they are. What do you say to them?
Amy, you want to answer that first?
I'll start, and then you chime in, because I know we both feel strongly about this.
Yeah.
The science is our backdrop. So with science, the science is solid. And so we've often said, as we teach our method to both medical and dental providers, that the science becomes your backbone of understanding. And with that knowledge, no one can really shake you off of that vantage point, because the objectivity of the science demands attention. And there's such a lag time in the insurance model of acceptance, and somehow the medical and dental consumer rather views their insurance plan as the default scientific filter of what has merit and what doesn't. Mm-hmm. And so, as Brad said so clearly, with education, both of ourselves, of our colleagues, and of our patients, all of a sudden that science elevates the demand of care, and sort of the riffraff of naysayers goes away, because the science really holds our attention.
That's what I've seen happen too. Dr. Bale?
Yeah, no, the science is solid. And another way to make sure the healthcare provider is solid with it and can't be shaken by some skeptic is to be personally engaged. I mean, Dr. Doneen is my provider. So, I'm not worried about having a heart attack or stroke, because she takes care of me, and I experience everything that you're experiencing with your care with me. Right. I mean, I do the oral health testing. she looks at my inflammation. And so I think any healthcare provider who really wants to be strong with this and make sure these skeptics can't touch them is they need to personally be engaged with this type of care themselves. And that way they can make sure they're going to maintain their quality of life for however long they live.
Mm-hmm.
So
I maybe lied a minute ago. I said 2 last questions. I want people to hear how they can learn about you and your work, but I don't know, Joe, if you have any of my data in any of those slides there, but I'm one of those patients where a bit of a skeptic 5 years ago, got involved, learned about my genetics, very religious about going to my hygienist and dentist every couple months and getting care. I think Dr. McClellan said I'm one of their best customers because I get my oral bacteria tested every 2 to 3 months. I just did it again a couple days ago, and monitoring it because I have that. I don't know if you have the graphic, Joe, but I'm not afraid to talk about that publicly. I've given presentations on my personal data publicly, and my blood work and my health has improved dramatically in the last 5 years. Now, is it solely the periodontal care? No, but it's played a major part in it. I am sure. I don't know. Dr. Bale, you might want to expand on that just a tad, and then we'll talk about
absolutely. Yeah, so when you first came in, your arteries were on fire. We had the medical tests, the biomarkers that clearly illustrated you were in trouble. You had arterial inflammation. And certainly one of the significant contributors to that was the high level of the high-risk periodontal pathogen, Treponema denticola, that you had. And you went and had therapy for that. You did eradicate that. And the next time we tested you, which was within 3 months, that inflammation, that fire had been extinguished, totally extinguished. And now over the years, you sent me a beautiful graph of all your fire markers, inflammation markers. And yeah, you've been ice cold, and we're going to keep you that way.
Yeah.
And what you may not realize is when you're ice cold, we would now argue the greatest unheralded benefit of the Bale-Doneen method is not preventing these symptomatic heart attacks and strokes, which we certainly do. But after doing it for 20 years, what we realize now is the greatest benefit of our method is putting that fire out prevents you from developing that microvascular disease, all those chronic diseases of aging again that rob us of our health.
Right.
And as oral health care providers, you're helping to do that. I mean, it's ridiculous. Like Dr. Doneen said, there's currently a 12-year disparity between how long you live and how long you stay healthy. That's crazy. If you want
so where can people learn? I know there's questions, and Joe may get to them in a sec, but let you guys give a quick pitch. Where can they learn about your method? And I know you have things that they can stay up to speed on. And
Sure. Joe, you want to put up the last slide just so people can have a visual on that? Something really, COVID has brought in a lot of challenge, and there's good and bad coming out of it. Yeah. One of the things that kind of threw a curveball at us was we were giving our live preceptorship course in April and realized that that's just not possible. So we did a live course, virtual. And so what we have now that we've not had before is this live course that's certified for both CE and CME, available for people to take the whole course, which is extremely exciting. And we've got a webinar with you coming up in July, and mainly PDS has been so supportive and is going to offer our preceptorship, which is normally a $2,500 $100 program to your affiliates, which is very generous of you, by the way, for a price of $749, and that gives them 16 hours of CE certification, and the medical providers in your community get 16 hours of CME certification through that as well. So we're really excited, just really excited to offer that. And it's one of those, I guess, good things that has come out of the COVID-19 crisis, because we haven't had this before. So we thank you truly for your support, and you've got our website and the link there, and your affiliates are extremely fortunate that they can have this at that cost. So we're grateful to you.
Well, thank you very much. And I appreciate both you guys. And I love getting my monthly updates from you, Dr. Bale, and all the research. I tell everywhere I go, I tell your story. He is the encyclopedia of science on the oral systemic link, and he's not even a periodontist. He's an MD, so it's great. And Joe, I know there's some questions up there you may want to hit on. We got time for one or two.
Sure, a lot of great dialogue going on, looking at the chat, looking at the questions. First question's from Marko Vucic from the ADA. He said, to what extent do panelists think your average cardiologist or internist know the evidence and actually act on it? That's the first question, and I'll follow it up.
Well, I would argue the cardiologists are not very good at that overall, because they're engaged in end-stage disease. What their work involves is when the patient has a heart attack, they develop angina. So they're dealing with that end-stage problem. So they're really not educated in prevention as a rule. Now that's changing. We have more and more cardiologists that are engaging with our method, and they're getting excited about preventing those end-stage problems. But for the most part, that's how cardiologists are trained. So really a better question would be, how many primary care providers are aware of this, like family practice, internal medicine? And that definitely is gaining ground, and you see it more and more in all the journals, how they're pushing wellness and maintaining health. So more and more primary care providers certainly are getting on board with the importance of the oral systemic connection with cardiovascular disease. But the cardiologists, for the most part, aren't there yet, because their training involves dealing with the end-stage problem. In a way, they're so busy putting out the masters, they haven't got.
Yeah, there's so much of it going on. They're so busy fixing things that are broken that. Marco had another question too.
Yeah, second part of that question is, do care protocols in any major healthcare system, Mayo, Cleveland, et cetera, include anything oral related for heart disease patients?
I'll go ahead and answer that. I can't speak to exactly the protocols at Mayo or large institutions, but after the CANTOS trial was published, inflammation became a very known and appreciated dialogue in all institutions and in all levels of medical care. So as inflammation is appreciated, different institutes through different models, right? Because Cleveland has a now functional medicine department. They are looking at oral health as part of that window. So things are changing. I would not say it's optimized yet, but through that dialogue of inflammation, lack thereof, meaning health, or if inflammation is present, there is the potential for disease of any type, whether you're talking cancer, heart disease, etc. So it's changing, but it's not perfect yet.
I have a question here I'm seeing on dental safety. The whole idea of, you probably read some of the articles, aerosols and hygienists cleaning teeth, and dentists and dentistry got shut down during the COVID crisis. I mean, what are your thoughts on that, given all that we just talked about for 50 minutes, the kind of risk reward of taking care of your teeth versus what happened to our industry and we got shut down?
I think it's a shame. And overall, there's probably no cleaner place to go in terms of a healthcare facility, in my opinion, than a dental office.
Yeah.
And it always has been that way, and now it's even more so. So I've been to my dentist. I was one of the first ones lined up as soon as the state allowed them to open up. I wasn't like, oh my gosh, I got to go to the dentist. I was like, yeah, I can't wait to get my teeth cleaned again, make sure I'm still okay. I'm not worried about the COVID-19. I figure it's a very safe environment. So.
Good, yeah.
Also, too, our part of the precautions that delayed the opening were to protect the employee, protect the hygienist, and protect the dentist. Even more, the patient risk is extremely well controlled and always has been. Dentistry, as Brad said, is a great environment for risk for the patient,
Right.
But all the additional equipment and protection really was on behalf of protecting the hygienist from all of the stuff going on. But to that point, we could not wait to make sure our patients were in there, because having a delay of an industry like dentistry in a world that is driven by inflammation, and I'm talking atherosclerosis, is a real travesty, because these patients can get a really big problem really, really quickly if it's delayed. Think about it like this real quickly. Let's say a whole industry of pharmaceutical sales, and someone's on it because of genetically inherited condition that needs to be treated, and that was just eliminated for 3 months or whatever during a crisis. I take it that seriously, that it was really unfortunate. So I'm thrilled that dentistry responded so quickly, and that the hygienists are protected, the dentists are protected, and get those offices back up and running.
Yeah, we've, I think the industry has done a great job over the last 30 years. Obviously, dentistry was in the thick of it 30 plus years ago when the AIDS crisis happened. So my stance is dental offices have always been safe, and they're even safer now. And I just went and got my teeth cleaned too. So there you go, Dr. Bale.
Well, Steve, I want to give a quick shout out to you, because I know from one of our conversations, again, PDS is leading the way. As soon as you could tell this COVID-19 thing was a reality, you went out and purchased, correct me if I'm wrong, millions of dollars worth of personal protective equipment so you could help those dental offices that you work with stay open and taking care of people. So again, I mean, you're a leader. You're leading the way.
Thank you. Yeah, we were able to keep open approximately 700 offices around the country, and 40 or 45,000 new patients found one of our supported dentists during that time, because their dental would close. So we helped them, and a lot of it was endo abscesses that we. Who knows how many lives we saved there. So it's great. Thank you very much.
Congratulations. Yeah, I'm proud of what PDS is doing. You're really the leader in the industry.
Well, I want to thank you two for all your work. It must feel like rolling a big boulder uphill in the healthcare profession, but you guys just don't give up, which is what I love about you two. And you keep pushing ahead, and we're going to get way deeper in this now that we've started Epic. We actually have Epic implementations in already. So this isn't just a thought anymore. They're in, we're going to beta in a couple days, and then we're going to full rollout. So it's super exciting.
All right.
Yeah, I want to just thank everybody that participated. I think you guys did a fantastic job. I think this webinar is part of the solution, and continuing to educate, to continue to grow the awareness about the mouth-body connection, the oral systemic link. I just want to encourage the listening audience, those of you that are out there and have found this engaging, exciting, and full of truth for the betterment of humanity. This is what this is all about. There are going to be more engagements like this coming up in the not too distant future. Dr. Doneen referenced it, but bringing the community together like this is really good for dentistry. It's good for patient care. And as we do it, we will have an impact. So I just want you to keep your eyes open for future opportunities like this, and engage Dr. Bale and Doneen's site. They've got a lot of great information, and continue to look like for materials like this coming out from PDS. We will be sure to share this stuff with you going forward. So thanks for attending.
For this, will we be posting this somewhere? It'll get posted on social media so people will get to find it too, right?
Absolutely, absolutely. This is recorded, and again, there's so many of you commenting on the side, on the chat. It's really exciting what this initiative is, what's happening with this initiative. So thanks for all your attention.
Thank you both so much. Thank you for your time, Dr. Bale, Dr. Doneen. Great to see you too. I'll be seeing you soon because I'm going to be down in Nashville soon. So I'll see you in person sometime in the next couple of months.
We like traveling with leaders. So thank you.
Thank you very much.